Fine. So the main topic that we bring in was okay, role of optometrists in glaucoma. Okay. So the considering the audience is going to be students of optometry and also practitioners, I had made it very basic aspects, right? And then we'll end up with referral. How do you go about with the referral? So based on the time, we can further have case discussions also, but let us take it up one at a time. I have a disclaimer on financial interest. Yes, I am part of Artiles, which is an company that we are in. We develop OCT and fundus imaging systems, and there is a huge applications in glaucoma that we do. And in Neurasim, we also provide VR-based solutions. So that is also going to be in the field of glaucoma eventually. So let us first understand glaucoma. Glaucoma is optic neuropathy, a progressive optic nerve disease. So whenever you, as a clinical person, is going to say that somebody is glaucoma, please confirm multiple number of times whether the optic nerve damage is significant and is it pathognomonical or is it really a glaucoma related optic nerve change. Without optic nerve changes happening and the corresponding visual field, terming somebody as glaucoma is a wrong thing. Okay. In this, angle closure, elevated IOP, these are risk factors. Like, for example, a high BP can be there, but that is very mean that somebody with a hypertension will have a heart disease, right? So glaucoma is like, you can't say everybody with BP is having a heart disease. You would agree with me, right? Similarly, you should not give a patient a tagline as glaucoma unless and until optic nerve is damaged. So this is something I'm taking a minute here so that you will know very clearly that you should never make a mistake of saying somebody, because you have IOP greater than 22, you have glaucoma. No, please look at the optic nerve head and the visual field. When both of them show defects that are uh, corresponding to a glaucomatous appearance, then you call them glaucoma. Okay, fine. Is this a problem? Yes, it is. Almost 6% of blindness today in India is because of glaucoma, and it's irreversible. And 8 out of every for adults over age of 40 is at risk, and the numbers becomes even more with increasing age. By 2040 in Asia, wherein I think India and China will be will occupy almost 70% or even quite a good amount of global population, we see that almost 28 million might have glaucoma. Okay. So for you to understand from a clinical standpoint, if we develop our skills and our competency to detect four major types, okay, of glaucoma, that is the first thing to do. One, we all know it's open angle glaucoma, a more progressive type of glaucoma, okay, and there are various types. If it comes in young age, it's called juvenile glaucoma, and there are the presentation is slightly different. You have ocular hypertension where we talk about it, wherein there is no optic nerve changes and very early perimetry changes, but the pressure is slightly higher. So this person is like a person who's always having a high BP. So you can see that I'm slightly on the obese side. So I slightly have a high BP. Doesn't mean that I'm having a heart disease, right? So ocular hypertension is a condition that can predispose into glaucoma, right? And then normal tension glaucoma is a patient who has pressures that is less than 21 millimeter of mercury, but there is a significant optic nerve head damage. And these are patients mostly older in age. And the second classification of glaucoma is our angle closure, otherwise called as closed angle glaucoma. This starts with a variant known as occludable angle, where it's a very early form. Only the front portion of the eye is a little narrow, but there is no other risk of glaucoma. But the next part is primary angle closure. Slowly, because of this narrowing, there is an increase in pressure that comes in, or there is blockage, there is synechia forming in the angle structure, or optic nerve is getting some early changes, but there are no visual field effects, right? In this kind of a stage, we call it primary angle closure. If you would again see that in the second classification, there is in occludable angle, we don't say occludable angle glaucoma. We don't say primary angle closure unless and until optic nerve and visual field is shown difference. The third type is the congenital glaucoma, which is born, children are born with this kind of an defect, which is more associated with the significant strong family history and other risks, right? And secondary glaucoma, which is what you would see more in a clinic, right? In a primary eye care practice, in optometry practice, you will end up seeing more of open angle, angle closure, and secondary glaucomas. 90% of glaucoma cases are due to POAG mostly, and the this is the type of glaucoma where they will not know what is happening. That is why it is called silent T for vision, right? So you would see that when you look at the angle structures or you look at slit lamp Van Herring, the grade will be 4, but the pressures in these patients will be greater than 21 millimeter of mercury, okay, adjusting for the corneal thickness variations, right? They might have systemic diseases, or there will be no other cause for why the pressure has to be high. But in this patients, the optic nerve head shows significant damage, and there is a perimetric change, corresponding perimetric change, right? This is POAG. So three things: IOP should be higher, angle should not have any other physical obstruction, okay, should appear perfectly normal. So your skill of gonioscopy is very, very important. Please, as a clinical practitioner in India, learn your good skills of doing a good gonioscopy, right? And and do a 90D evaluation minimum to look for a 3D optic nerve head. And based on optic nerve changes, refer for perimetry. If you have a corresponding visual field defect, then these four parameters together is what you call a POAG. Now, the second variant of open angle is the normotension glaucoma, where the pressures are not usually greater than 21 millimeter of mercury. In IOP, you should remember that you should not take a snapshot IOP, which means that only one time I do IOP and suddenly there is 24, and you shouldn't say that patient is glaucoma, because that could be a variation, right? So diurnal variation, there is fluctuation of IOP. Even when you do 24-hour admitted every 2 hours do IOP, a non-intensive glaucoma patient will not show pressures beyond 21 millimeters of mercury, but there will be huge fluctuation. He will range from 7 millimeter to 17 millimeter or 19 millimeter. Okay, more than 8 millimeter of fluctuation will happen from morning to night. And these patients are usually older. So since older they are, neurodegenerative changes are quite common. Glaucoma is a neurodegenerative condition. Okay, it's similar, it has been compared similar to Parkinsonism and Alzheimer's too, right? So we have to understand that we are not dealing with a disease of the eye, but we are dealing with the disease of an aging neuronal health, right? So that is very important. And a very easier way to look at is cup-disc ratio, which is a very easier thing first when you look at optic nerve to look at. Angle closure glaucoma. Yeah. Indian patients have more of angle closure glaucoma. Okay, we and the Chinese and the Asian population have a higher prevalence of angle closure glaucoma, and this is very important. Wherein you will only find that in a primary angle closure glaucoma, it is there are no other reasons but with aging and with the lens becoming more cataractous and moving in front, it kind of pushes the iris in front and blocks the outflow of aqueous humor. And when this is persisting and there is a pupillary block that is happening, then there could be a sudden rise in IOP. And very, uh, this is a type of glaucoma which can show good amount of symptoms. Okay, wherein the patient will come with severe red eye, will have unreactive pupil, right, and the pain will be very high. But open angle glaucoma, on the other hand, I told you that it's going to be asymptomatic, and that is more prevalent in globally and also in India. But if you look at numbers of the group of angle closure, which I told occludable angle PAC, the numbers are quite high in Indian population. So to detect angle closure glaucoma, again, optic nerve head changes and visual field is the very, 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 very important one. Beyond that, what is making a difference is a good gonioscopic skill. Okay, a good slit lamp evaluation of the drainage angle and the depth. So these two are a very important parameter. Okay. Secondary glaucomas. So we talked about primary glaucoma, which is open angle and angle closure. Secondary has some other reason. It can be because of something is blocking the trabecular meshwork, something is clogging it, or there could be inflammation. There could be some other uveitic condition that is causing episteal venous pressure, right? So circumciliary congestion will be high, and therefore the fluid is not going. So that's a secondary reason to it. Or the lens which is there behind a subluxated and moved in front, right? So there is some other reason that is causing that pressure rise. These are patients who need immediate care and surgical referrals very quickly. But other types of glaucoma, open angle and angle closure, if you become competent enough with telehealthcare, if you do OCT, fundus, and telemetry, you can easily do a teleconsultation on these and start treatment for these patients too. Because this is a chronic condition. Primary glaucomas are a good business for any practice because you get one patient, you get three free. If they have more brothers and sisters have glaucoma, so ensure that you call everybody because it is a genetic condition that can be more prevalent among their siblings, right? So it's a 1+1 offer kind of a thing. So primary glaucomas are something that optometry practice can very easily take care of, but documentation using very high data is very important. Sorry. Using OCT or fundus imaging, this kind of documentation is very important considering that we are all going to be regulated through the National Council. So a practice should have the best of a care that is provided in ophthalmology. Services should be equivalently done in an optometric practice. Otherwise, it'll be a big challenge for you because glaucoma is something very subtle that you might miss out and the patient will lose their vision by the time they come for the next visit. Okay. So again, symptoms. So this is the reason why a patient comes in. The first term itself is an oxymoron. I called it symptoms. The first thing I say is asymptomatic. So many of the patient might come for their progressive lenses. They can come for their glasses. Okay. Or they could have just come in because his mom has come and I want to do a check. Or his brother has come and he wants to do a check. And you evaluate, do a comprehensive glaucoma evaluation, you will find early signs of glaucoma. So it is very important that a comprehensive uh, regime of series of tests are done in glaucoma. And some patients with even primary open angle and many with angle closure glaucoma and secondary glaucoma have blurred vision. And after they lose significant amount of peripheral vision, they will say that I am tripping over something when I walk. Okay, those are the kind of symptoms they have. Redness and eye pain are more seen, and halos are seen in when they have an acute angle closure attack or a secondary glaucoma that is causing a significant raise, right? But otherwise, 70 to 80% of glaucomas are asymptomatic. So, how will such a condition be detected? It's not a simple thing. So you cannot just do one test and find out glaucoma. You need a suite or a comprehensive examination on you. So the first in any healthcare is good history taking, right? So you start with a good history. Understand what is affecting that patient. Why is he coming? What is the reason? Is there a risk of glaucoma? We'll talk about these things. Then a good visual acuity refraction so that we can understand that if he's hyperpro, then there's angle closure risk is high. If he's slightly myopic, then he might be more open angle in fact. So there is no direct relation, but for quality of life, we need to give a good pair of glasses. And in optometric practice, that is a very important means of getting your revenue, right? And these patients, when they have uncontrolled glaucoma, they frequently have change in glasses. That can also be a good sign for you. So when we say in younger age, myopia, we see frequent change. In older age, due to glaucoma, there might be a sudden change in their refractive error every time. They say, this is my fourth glass I'm changing in the last 3 months. Could be a small hint. Then you should think of, okay, I should do a good glaucoma evaluation because he could have fluctuating IOP, and whenever he's getting tested, that could be edema in his eye, and they're getting a different refraction, right? So then you do external examination. May need to look for any congestion. If there's a significant redness and things, You have to call your ophthalmology colleague right away and not wait for doing complete evaluation, because you need, in fact, this could be an emergency. And a very important clinical test in glaucoma is pupil evaluation. Okay, RAPD, relative afferent pupillary defect, right? So you have to look at RAPD, okay? And if you have an ancillary, mostly it's used in ARND cases, but even in glaucoma, if they have Giron's scotoma or a centrocecal defect in the 5-degree field, which is sight threatening, right? If there is some scotoma in the 5-degree, then it means that he's getting blind. He's at higher risk of blindness. So you can also use an ancillary grid, but color vision screening, especially with the blue on yellow defect, is seen. Then I call it the Bhangra dance, which is confrontation test. You could do it, but it is not highly robust and reproducible, because if I show my 2 big fingers, they can easily see. But if it's a thin optometrist who's showing finger, they might not even see, right? So we are not repeatable thresholding is not happening in a confrontation. But if you're in a screening setup, you can do this Bhangra dance. Okay, you do it with both the hands and then kind of see which side is the visual field defect is, right? So the most important of the thing, because the modifiable risk factor in glaucoma today, though there are genetic therapies happening, there are new age therapies coming in, but in an affordable way, the first thing that we can keep control in glaucoma is the pressure. Either maximum medical management, okay, or if not, then our glaucoma specialists will do surgical management. So they basically try to control the intraocular pressure. But along with intraocular pressure, gonioscopy is another very important skill that you should learn and do. So clamp me, you will look at angle structures, okay, and look for clinical signs. Sorry that in that loop I had missed out slit lamp. So slit lamp is also a very important thing. And gonioscopy is a very important skill. And in this group, if you can just give me a thumbs up for things, how many of you do gonioscopy? I'll be happy to know how many of you do gonioscopy. Right. Just give me a thumbs up in the chat so that you don't sleep off. Post lunch session is always quite challenging. Right. I had to keep you guys engaged on an online session. Right. And the last row is the heart and soul of glaucoma care. Right. So because we told that glaucoma means disc and optic nerve changes, RNFL changes, and visual field changes. Without these two methods, either you can refer them to an eye hospital if you don't have them. But today at Artiles, we make very affordable fundus imaging and OCT. Okay, and OCT that is just at 12 lakh rupee, wherein 4 of you when you are practicing, you can buy an OCT and use it in clinic, right? So that's how easy it is. And there are portable visual fields that are under 5 lakhs today. So a good glaucoma care should at least have an OCT and a visual field effect. So coming to risk factors, you have the non-ocular risk factors, which is age. So the older the patient, you have to already diagnose glaucoma in your mind. And you have to compete in your clinical by doing comprehensive clinical examination. You have to rule out, yes, this patient does not have glaucoma. Okay, till you have substantial evidence, older the patient, ensure that you are doing all possible examinations in the clinic. Again, ethnicity. African population and Asian population. African population will have more of open angle type, and Asian guys we have angle closure and open angle together. And if you end up seeing Japanese population, then there will be more of normotensive glaucoma. Okay, so genetics and family history is very important. So if the brother has glaucoma, so how will you ask them? If you simply ask, do you have glaucoma, right? They simply shake their head or say, I don't know one things. So a very good way to simply ask this, show them a timolol or things. OL, like, because many of them are using beta blockers, they will know that these are beta blockers names. Like if it's a learned person, say that if there's an eye drop like this with the OL, timolol or carbaxolol, is your brother or sister putting it every day? Putting it every day is a very important thing, right? Because glaucoma is not a one-day kind of thing. They have to keep on, be highly compliant with their medication. So ask the right history. And snoring and obstructive sleep apnea. There are a simple 2-page questionnaire that will give you whether a patient has got an obstructive sleep apnea. That could be used. And with aging comes these packages, right? Diabetes, hypertension, and if it's too thin, a patient who has had blood transfusion, they might have hypotension, right? Systemic diseases also has an influence in the prevalence or the occurrence of glaucoma. And if the patient is using any steroid, right? So alone, prednisolone and those kind of drugs. So it's better you have an empty bottle of these so that the patient will remember the color or the name in it, right? If he's using a steroid, then those kind of patients will have a higher risk of increase in IOP. Smoking and migraine are also a risk factor, but let us look at that in the order. Coming to eye aspects, when you're doing IOP, if there is a difference in IOP of 3 millimeter of mercury between the eye, then suspect glaucoma in the eye, which has an higher IOP. Second point is initially we thought thinner CCD is the problem, but now research evidence is showing that it need not be, right? So CCD is not a very important thing. So even if you don't have a pachymetry, that's fine, right? Corneal hysteresis is there in a high-end tertiary healthcare clinic or a better established clinic you might have. But a slit lamp is there in everybody's clinic, right? Today, all of you are good practitioners of contact lenses. You would have a slit lamp. Look at a shallow and AC depth and slowly buy an gonioscopy right away at the end of this session, which is just costing around 8,000 to 20,000, right? And start using it on a patient. Okay, so today in a world where you can get data on Google, you can see so many courses happening in gonioscopy. You can get umpty number of images and you can start to learn. If you're not learning, don't wait for some yarn, somebody to come and give you that yarn. Okay, you are practice that needs to be done. Myopia and open angle glaucoma are related. When you see the optic nerve using an 90D, then sorry. Hey, am I audible, right? No, please let me know. Give me some
Yes,
feedback also.
yes, you're audible, sir. Yes.
I'm sorry that I'm making it monotone kind of a thing. So I saw the chat in between. Uh, okay, there are only 2, 3 of you, Sujata Sharma, Mumtaz, Kazi, but we have 38 attendees and only 2. Oh, sorry, 16 attendees, only 2 of them do gonioscopy. So please get motivated. I want all 16 of you to take it a very important thing that you will learn gonioscopy and 90D evaluation from today on and keep yourself a target. In the next 2 months, you can easily learn that skill. And the investments you are going to make is only 30K, right, for both these lenses together. A good Vogue lenses will be around 30, 35,000 if I'm not wrong. So these are 2 things so that you can look at angle closure and you can look at this very important thing wherein optic disc hemorrhage. When you look at the optic nerve head and you see a splinter hemorrhage, I'll show you some figures, then that is highly pathognomonical of glaucoma. The word pathognomonical means pathology is the glaucoma, mnemonical is highly aligned to. This is exactly a sign which when you see, then that is glaucoma for sure. Okay, fine. So in the history taking, there are many aspects to it, but when you are dealing with the elderly patient, please ensure that don't simply ask them what medications they use, right? So it is better you keep the common steroids bottles or common medication ka ek strip. It might be an expired strip, that's okay, but you just show those things. Do you use any of this? Or do you use an antihistamine like an allergy thing? So try to explain to them in a common man's terminology, right? And then you look for aspects like any history of trauma and positive family history, right? So one of the alarming signs is if there's an early onset of presbyopia, and when they say I am having difficulty in driving vision, this can be because of cataract, but could also be because of glaucoma, right? Frequent change of glasses is a small clue, but not a very high thing. But these are patients, when they have very high diurnal variations and angle closure patients, they might have frequent change of glasses. Color vision and blurred vision early in the morning or afternoon, especially when their eye is closed. So when there's edema due to glaucoma, then that can. In the pediatric group, when you're dealing with a congenital thing, ask for a good history, right? What was the complication during pregnancy, right? Rubella infections, or they might use a forceps delivery that could have created a small damage to the, because the forceps is kept on the side and it can even create fractures in your orbital region, but also it can affect the ocular abnormalities, right? And then very strong family history of glaucoma and their consanguinity. Have they married within relations? And those are things that are very important. So when you're looking at congenital glaucoma, you will see that the child will have epiphora, that is too much of watering. Photophobia, the child cannot even keep the eyes open for even a second or even a minute, and blepharospasm. So the lids will not keep moving very clearly. Right? Ophthalmos, or very projected eye is a very thing, and whitening of the cornea, which is basically opacity that is coming up in the eye. Right. So visual acuity, do a good logmar acuity. Okay, that is always my recommendation. And then you can look for hemangiomas or episcleral problems. Sorry, and do a good pupillary evaluation, right? And then Amsler grid if you have. In slit lamp, Van Herrick test has to be done very, very appropriately, right? There are a couple of variations to it, but basically you compare the width of the corneal reflex to the dark region, that is the gap between the colored portion, the iris and the cornea. So the gap is what you're looking at. If it is 1 times this width, then it is grade 4 and above. And if it is less than 1/4, okay, then it is considered angle closure, very thin angle. So anybody with grade 3 or grade 2 and grade 2 or grade 1, and some patients with grade 3, you have to do gonioscopy to rule out why is there really a angle closure that is there, right? So Van Herrick is a screening, but confirmation is gonioscopy or an anti-segment OCT if you have access to. Okay. So a patient in a sitram will have these kind of things: circumciliary congestion, an edematous cornea. In a patient with significant angle closure attack, they will have glaucom flecken, right? So which is a whitish appearance in the lens structure. Pseudo exfoliation happens in adult angle closure glaucomas, right? Which can be also a secondary glaucoma. So raised IOP is the easiest modifiable factor. Applanation tonometry is still the gold standard, but we do have rebound and other portable tonometers which can be used. Schwartz has become history because Schwartz tonometer is indentation tonometer. So, and that is not so right. It doesn't give the correct IOP. So I would more look at an applanation tonometry that you should have in your clinic. And you would have a cutoff of over 22 millimeter of mercury. So that when you also have a CCT, a pachymetry, because some of you will be doing orthokeratology and other therapies. So if you have access to pachymetry, then one of the easier ways you can use this kind of a chart. 545 or 550 microns is considered the normal Indian corneal thickness. Actually, 522 even we have normative data, right? But anything less thicker, then you reduce the IOP. If it is thinner, you increase the actual IOP, which means that applanation, when you're putting the flattening pressure, because the cornea is thin, it is not resistant. So you are getting a lower value, but actually the IOP will be more higher. So if you get, for example, if a patient with 445 microns is there, right? These are not patients I'm talking about post LASIK, but these, even for LASIK patients, you should do some corrections where it is slightly more complicated than this, right? Say, for example, you get a 445 microns of corneal thickness, and in this patient, you get a value of 20 millimeter of mercury. The actual pressure is probably near 27, is what this correction factor talks about. Right. So coming to the next important test, I think all of you agree with me that you will learn to do gonioscopy properly. Okay. So gonioscopy is a very quite subjective test. I would again motivate you. Don't get scared. It's again, you guys are very good clinical persons. So It's only practice that makes a man or woman perfect, right? So the more you see the images, what are we looking at? These clinical features. Okay, you follow the iris, look for the ciliary body band, or is this ciliary spur seen, or is the trabecular meshwork seen, or is it only the Schwalbe seen? Depending on what you see in that region of the angle structure, you say whether it's closed or open. Okay. In the trabecular meshwork, you will have pigmented trabecular meshwork, which is posterior trabecular meshwork, and non-pigmented region could be ATM, that is anterior trabecular meshwork, right? You look at that and grade it, right? And along with this, you also look at the concavity of the iris, which is also a very important sign in gonioscopy. In case you have access to an OCT, then you do an anterior segment OCT. Okay? Say, for example, this is an example. So this is a beautifully open angle with no other pathology. But if you see in this patient, on the left, you are seeing synechiate, which means physical additions that iris and cornea is having, right? And this is an angle closure glaucoma where I'm not able to see any of the angle structures, right? This is a pigmentary glaucoma where there's too much of pigments. Though they have an open angle, they have too many pigments on the angle structure. Fine. So what we do in as a startup, why I moved away from just being a clinical person and develop medical devices is to make it accessible to all of you, right? So in Artiles, we manufacture the world's most affordable OCT and also a very portable and operator independent fundus imaging, where you can do fundus imaging sitting in your clinic anywhere across the globe. So device has to be there in a center and you can do it. So this is the kind of examples that do. So what you see is undilated optic nerve head scans, you can get corneal scans, and this angle regions can be scanned. And these are fundus images on the right of glaucoma patients. On the one in the right bottom, can you see a small hemorrhage that is there? This is a glaucoma patient with a splinter hemorrhage and the corresponding nerve fiber layer defect, right? So we need to look at sub-disc ratio, the optic nerve assessment. Okay, look at what is a patient, what is the cup disc ratio is, adjusting for the size of the cup on the disc. Say a glaucoma training, it takes 6 months altogether. So I'm only giving you just a small glimpse. But when you're looking at a cup, look at the size of the optic nerve head and you grade the cup to disc ratio and the nerve fiber thickness. Okay, these are the two important things. Cup disc ratio of difference between the right and the left eye of more than 0.2 is also very important. Neural rim, ISNT. A healthy person will have a thicker inferior part of orange region as compared to superior than the nasal and temporal. But the ones with disease with glaucoma will have a thinner region inferior and superior as compared to nasal and temporal. This kind of an neuroretinal rim is considered pathological, right? So you basically have to look at this optic nerve head, and this is what an OCT image is for you, right? And you use optic nerve fiber layers, and defects in the nerve fiber layer can be corresponding to that of the visual field, right? Say, for example, here we use AI in Artiles, wherein this is a thing where we mainly focused on retinopathy. But we also found that only diabetes is not enough. So we trained our AI tools to also detect glaucoma. So some of the examples, for example, this is a patient with glaucoma, wherein the diabetic retinopathy was not there, but there was a significant optic neuropathy that you could see. Superior thinning is very well noted in this patient, right? This is an optic nerve scan in our OCT, and we look at RNF thickness reports that you could see here, and there is an inferior thinning that is seen. Visual field analysis is very important, right? So we did Amsler, which is quite kind of a screening for central scotoma, but you do standard visual field to look for what is the type of defect a patient has, right? So it could be nasal step, temporal wedge, superior arcuate defect, paracentral defects, Okay, and slowly it becomes a biarcuate. And by the time the patient comes to this stage, whatever loss has happened can never be got back because the nerves have also died, right? So visual field itself is a bigger class. But what I would want you to look at is this is an example of an Humphrey Sita chart. You have to mainly look at mean deviation, but also look at visual field index. Lower the number, then higher is the risk of defect, and look for the pattern. If this pattern is corresponding, because eye is a plus lens module, so if you see a superior defect, then the inferior part of the optic nerve head of that eye should be affected, right? So this is an example. I'm going to finish this talk today with this one because I it is I don't want to over trust this. So for you, this is from American Optometry things wherein there are slight variations that we can also make as you become a registered optometrist in India too. So when the patient comes to an optometrist, say if he's normal with risk, somebody with no risk, which means that the pressures are always less than 21, not measured one time but couple of times more. Then if the IOP is between 22 and 25, there is a risk, but optic nerve head is very healthy. Then you just do a optic nerve head evaluation and visual field as baseline, and OCT if you have access to, then that is good enough, and you follow the patient. They don't need treatment at this point, right? Okay, and they only need to be reviewed once in every 6 months or 1 year. High risk patient is the one who has very high IOP and optic nerve also showing significant changes. Then you refer them for the care. A glaucoma suspect is somebody who has suspicious disc, RNFL, and normal visual field, right? Or normal disc but a suspicious visual field. Any of these combinations, but IOP being left. So three aspects: IOP, optic nerve, visual field, right? These three is what we play with in case of glaucoma. Okay. So low suspicion is somebody with lesser IOP, but who has probably an optic neuropathy, but not very sure, but normal visual field. Then continue seeing that patient, but call them for very frequent reviews. Repeat abdominal tests until the consistent result is obtained. You got it right. So if you invest in an OCT or a visual field, you now know how you can make the money, right? You don't do only one examination. You say that you come to me after 3 months, I'll give you a 50% off on your OCTs, right? So that he doesn't go somewhere else, he comes to your practice. Right? A high suspicion is a patient who has a visual field defect repeatedly in the same location. An optic nerve abnormality is very clearly seen, but visual field is normal, right? Either of these two is high suspicion. Then for this patient also, it's better you do an OCT and things, but also send him to an ophthalmologist so that if they also feel that they need start therapy, then it's better they do it, right? Glaucoma patients, early to moderate, definitive optic disc pathology with repeatable visual fields. In a visual field that is 6 decibel to 12 decibel within 10 degrees of visual field, then this patient needs to have an OCT and visual field, periodic visual field, and needs a glaucoma review. Okay. Advanced or acute is acute ankylosing glaucoma. Secondary glaucoma, a patient who has only one eye, already he has lost the other eye, and this patient do not handle on your own. Please have your glaucoma doctor see them, right? But in high suspicion and in early moderate, you can even do tele. Refer the ophthalmologist can also be done on tele if you have a visual field and OCT report. But if there is secondary glaucoma, trauma, and very significant visual field loss, then you send them to a nearby glaucoma practice. Okay. So these are some of the references that we have used, and this was our honorable Prime Minister who had visited our Sikkim office, where we show our optic nerve head imaging, and I'm happy to share that we did photograph uh, honorable Prime Minister's optic nerve head, and neither he has glaucoma nor diabetes. So that makes us even more happier that we have a healthy, visually healthy Prime Minister today. Okay, so let me pause my presentation here. Okay, and stop the sharing here. Yeah,
Thank you,
Liz.
sir. Yes, thank you for the information you provided
I'll
about
submit to you also. Yeah.
and you covered everything from types, symptoms, risk factors, assessment, everything, and that was invaluable. And it's clear that your insights will help many people take proactive steps toward preserving their patients' vision. I just would like to share one thing that when I was sharing about this session in all the optometry groups over the WhatsApp, so one of the person in the group, he replied saying there's no role optometrists can play, only prescribe glasses. So people still think
No
that,
problem.
we don't have anything to, apart other than prescribing glasses. So thank you so much for putting light on everything. We'll take questions now. Uh, Okay, there's one question that what is the reason glaucoma patients frequently need to change their glasses?
Very good. So one, it's not a highly published evidence though, but during my clinical practice and also at Chennai Glaucoma study data, what we saw is if a patient has got uh, fluctuating diurnal variations, or if he has a secondary reason, say for example, whenever there is a high IOP, the cornea is going to get edematous, right? So when they become edematous, there is a blurring of their vision that starts up, right? So these patients tend to have that. Okay, they would have gone to for refraction at one day where they had a slightly corneal edematous eye, and they would have got a slightly minus refractive error. What I'm trying to say is not huge diopter differences. He will say that I keep changing my glasses because, like my good friend whom you so told, if you only keep giving prescription glasses, what will happen is you will try to do refraction, try to refine the glasses and try to give a new pair of lenses so that you can make money through selling him. But he is actually suffering from glaucoma, right? So if you in your clinic has tested the optic nerve head, IOP, and slit lamp, then you are saving the patient from becoming blind. That is more important than just prescribing glasses. So I do agree with you that we have to prescribe glasses. But yeah.
Right. Right. Okay. There's
I
another question
again, yeah,
that, okay, about the relation between refractive error and glaucoma. Is it more associated with the hyperopia or myopia?
very good. So when you look at hyperopia, we know that the axial length is going to be less. These are smaller eyes. Myopia is a longer eye, right? So we call it axial myopia, right? So if you take up, leave an anophthalmic patient, okay, or a patient with very small anterior, overall axial length, but even a hyperope, if you do biometry, you will see that they have at least 1 to 2 millimeter lesser than an average Indian axial length, and the front portion of the eye, okay, because with aging, lens becomes thicker. Though it may not be cataractous, but it becomes thicker. So when a thicker lens, it moves front towards the iris. So there is a pushing angle closure is associated with hyperopia. Similarly, myopic conditions will have a slightly longer anterior chamber depth, so you can expect more of an open angle.
Right. Okay. Okay. Another question is, you said that pre-presbyopia could be an alarming sign. So does that mean more the accommodative demands increase the chances of glaucoma?
Not very sure. The aspect of presbyopia again, early presbyopia is more because of the lenticular movements that happens due to the thing in an hyperopic patients with aging. So I do not I would not say in the same way that you have understood. Like it is not like refractive error means glaucoma. No, we can't go about that.
Right. Okay. Another interesting question from Mr. Salik. What are the points to keep in mind while evaluating a patient at a primary eye care practice with limited resources so that we don't miss
Hmm.
out on glaucoma? So,
Beautiful question, Saleh. Saleh, very simply here. Do ensure that you look at you have to invest in a tonometry. And another thing is 90D and gonioscopy, if possible, right? If you're practicing in Asia, gonioscopy and 90D. These three are not very expensive. 1 lakh rupee is not something today is something exorbitant for you, right? You can pretty much put that investment. That is going to save you from getting any litigations eventually, right? So if you do these things, do a good refraction, do a good slit lamp. In the slit lamp evaluation, ensure that you are doing Van Herrick eye test. Learn to do it properly. Okay. Look at in a magnified way. Look for secondary reasons in the pupillary region. Secondary glaucomas, good number of them will have pupillary block. So they might have had a uveitic attack and the iris and the lens is sticking together in the back, right? A simple pupil evaluation here, a good RAPD test will help you think. So these 4, 5, but optic nerve with 90D, not with DO, with 90D, please practice. And Indian optometrist, gonioscopy. That's why I was once called Glaucoma Ramesh. Wherever I go, I used to say gonioscopy. Probably I would have worn a gonioscopy on top of my frames also. Please do gonioscopy because that is going to save you, like save the patient, more than saving us from litigations, but saving the patient a lot.
Right. Okay, we'll just take last question. Also, someone was asking about the presentation. So, guys, this is recorded session, and we'll be giving a link to the recorded session to the OCI members through the emails. So, we'll take the last question. Can you distinguish between the phacomorphic and a phacolytic glaucoma?
Yeah. Clinical signs are beautiful in that. Okay, so phacomorphic will not have very high level of immune reactions. Okay. To help understand others, phacomorphic is phaco is your lens, right? We all know that. We do phacoemulsification, cataract surgery. So phaco is the lens referred to, okay, in the Latin language, and then morphic is the size. The morphology is changing. So usually in a hyperopic patient or an aging patient, due to aging and things, proteins get adjusted, it becomes this big. But some patients, their lens will become even more bigger in size. When they become bigger, the zonules cannot hold them, right? Zonules are thin ligament strips, right? Very, very. It's a labyrinth, but it's having too much of weight on it. So the lens will fall in front of the eye and touch the pupillary region. And whenever it touches, every time pupil will expand, either they will have pigment dispersion happening or some other cause. So phacomorphic will not have high redness or uveitic condition like flares and cells. But phacolytic is rupture of the capsule. So the protein or a cataractous lens due to very high cataract, it has gone to a level that there is an immune reaction happening and the capsule in the front has ruptured and you are having that lens material in the anterior chamber. So moment it comes into the anterior chamber, your immune will think foreign body, right? So you will have flares, cells, circumciliary congestion, right? So this is how you will end up doing it. For phacomorphic, some clinics do an UBM and a scan, but that is not highly mandatory to do. So basically, you would know that okay, the visual acuity is not good, and these are very rare conditions, right? If I see 100 patients, right, since I've been blessed to see good number of glaucoma patients, so we have seen all these variants. So whatever you are seeing in Kansky or Corona, I have seen at least one of them everywhere, but more numbers are primary open angle glaucoma, angle closure glaucoma, and in secondary glaucoma, you will have pigment dispersion, pseudo exfoliation, and diabetic related. Okay, neovascular glaucoma. If these 5, along with the variations in it, if you are good at diagnosing, then you are a good glaucoma doctor. Yeah?
Right. Thank you so much, sir. There are still questions are coming up, but we are already past 4. So
I know. My apologies because I had challenges with my lovely system. It was not connecting at all.
no problem,
Yeah,
sir.
hi,
Yeah.
Koti. Yeah.
Yeah, so for you, if it's okay, we can give your email ID in the chat box so that
Yeah,
if
yeah. No,
people have
please, please. I'll,
questions,
I'll, I'll
they
share,
can, yeah, they can get in touch with you. So, on behalf of OCI and everyone involved in today's Glaucoma Awareness Month webinar, I want to extend our heartfelt thanks for your exceptional, presentation, and your expertise and passion truly shown through this presentation. And we are so grateful for the time and effort you took to share, your knowledge with the audience. So thank you once again, sir, for your generosity and sharing your expertise with us. Thank you,
Oh,
everyone, for
thank you.
joining this session.
Yeah.
Yes.
Thank you. Thank you all.
Thank
Yeah.
you.
Thank you, ma'am.